We're going to talk to Dr. Kelechi Okoroha about hip pain and FAI syndrome. If you want to introduce yourself a little bit more, tell them more about what you're doing currently as an orthopedic surgeon. Let everyone know a little bit more about what you do.
Sure.
Then get going.
Sure. So a little bit about myself and my training. I'm currently an orthopedic surgical fellow at Rush University. We provide high-level sports medicine care to our patients and athletes, including the Chicago Bulls and White Sox. Now, originally I'm from the South. I grew up with NBA dreams playing basketball in Houston, Texas. And then through basketball, I was given a great opportunity to obtain a pre-medical education at Xavier University while playing competitive basketball. So after college, I moved to a little colder climate in Washington, D.C., where I obtained my medical degree at Howard University. And then due to lifetime experiences as an athlete, I kind of developed an interest in providing sports medicine care to the athletic patient. Now, because I didn't get enough of that cold in D.C. following my medical training at Howard, I completed my orthopedic surgical training at Henry Ford Hospital in Detroit. And it was really there that I was able to conduct and publish various research projects with an emphasis on improving patient outcomes. And then following my fellowship at Rush, I've been grateful to be welcomed back to transition to my clinical practice back at Henry Ford Hospital. And we're really excited about a lot of the recent developments in the sports medicine program, including our recent partnership with the Detroit Pistons and the building of a state-of-the-art performance facility where we continue to provide really premier care to our patients and athletes. So that's a little bit about myself and my training.
Yeah, very cool. I mean, I've been following your stuff for a little bit now. Really cool stuff that you guys are doing out there. So focus of discussion today is going to be all things hip related. So let's start with the basics. What is the hip? I know you have a model there. Show us a little bit more about what the hip is, what it does. Why do we have a hip?
Yeah. So like Rush was saying, we want to talk about hip impingement, which is also called femoral acetabular impingement. But before we really dive in, it's kind of important to understand the structures of the hip and how it functions. So got my model out here. The hip is really a ball and socket joint. It's formed by the acetabulum, which is your socket, and your femur, which is the end of your thigh bone. And these bones are also covered with a lining called the cartilage, which allows the hip to move in a smooth, free pain range of motion. But in order to provide that congruent articulation, the hip relies on various supporting structures and muscles. So one of those structures is called the labrum, which is really this horseshoe-shaped structure.
Show them on the camera a little bit more so people can see on the, yeah, there we go. Yep.
So this is a horseshoe-shaped structure that sticks outside the acetabulum. And what that really does is deepen the socket and kind of provide stability to the socket. The hip also has a capsule, and the capsule forms around the thigh bone and the socket. And it also has ligamentous outpouchings, which also provide stability to the hip and allow the hip to function. So a well-functioning and stable hip allows the muscle surrounding the hip to kind of move the thigh bone and this articulation with the hip, which allows for motion. And any injuries to any of these components of the hip can cause abnormalities in the patient, which may lead to clinical symptoms.
Exactly. And the hip is so complex. We got the pelvis there, we got the femur, which is the thigh bone, and then we have the lumbar spine, which is the low back. And that whole hip area has been a very complex area for rehab specialists in general to treat. But for today's discussion, we're going to talk about FAI. Give us a breakdown of what FAI really is.
Yeah. So hip impingement, or FAI, which is called femoral acetabular impingement, is really a disorder characterized by abnormal contact between the femoral head and the acetabulum. So picture your acetabulum flexes and internal rotates, and you have an impingement in your thigh bone and your socket. Now, what happens when that happens is you have injuries to the labrum and the cartilage, which can cause pain. And the body's response to abnormal contact, the bone tries to protect itself. So if your femur continues to have abnormal contact with that acetabulum, it's going to form more bone on the femur to try to prevent that stress. And by forming more bone, your hip is going to impinge on the acetabulum in the earlier range of motion. And that cycle kind of continues, and you have decreased range of motion, you get a bump on your hip bone, which is called a cam lesion. So extra bone on the femur is called a cam lesion. extra bone on the socket or acetabulum is called a pincer lesion. And those are really the two main bony lesions in femoral acetabular syndrome.
Mm.
And then these lesions, when your hip collides, you can get injuries to the labrum, which are cartilabral tears, and you can also get cartilage defects in your bone. Now, what happens when the labrum has proprioceptive and neural fibers in them? So when you have that impingement of the labrum, it sends a response to your body in the form of pain, telling you stop doing this motion. And with that, other muscles around the hip can start to compensate, and you can also have additional pathologies in those muscles. So that's kind of a quick and dirty rundown on FAI and the typical components of it.
Exactly. Yeah. No, very, very cool stuff. And interesting to note too, you can have a combination of both CAM and pincer lesion, which I've seen some research saying that upwards of 85% of hip impingement is from mixed, but I've also seen as little as 2. So it's just a combination of both CAM and pincer. And I was going to say that the way I know it as well, FAI, as we were talking about earlier, is femoral acetabular impingement. It has 3 components to it. One is the MRI or X-ray finding, which we'll get into a little bit. The second is clinical signs. And then the third is symptoms. So if you don't have symptoms, you don't have the syndrome. There's no asymptomatic FAI. You can have an asymptomatic labrum tear, but FAI syndrome means that you actually have the symptoms, the clinical signs, and the MRI finding, which I think is pretty interesting.
Yeah.
So
I think you touched on a really important thing, because if you took an X-ray or MRI of the general population, especially the athletic population, you look like a guy who lifts weights, play basketball. I mean, we're going to have maybe a CAM, maybe a pincer. We might even have a labrum tear. But if we're not symptomatic from it, then we really don't have a problem.
Yeah.
And that's the same thing we found in the rotator cuff literature. If you take an MRI of everybody over 40, more than 60% of people might have a partial or full thickness labral tear that's asymptomatic.
Yeah, and the more I look into it, it seems like 10 to 30% of the general public do have some type of CAM or pincer lesion. It seems to be 3 times more likely in the active population. So 22% of non-athletes, 66% of athletes, we're saying have some type of morphology. Notice how I say morphology, not pathology, because morphology is just the way the bones have morphed. It's not necessarily a pathology that we need to address right then and there. So I guess here's a question. Does everyone that has a labrum tear or a CAM or pincer lesion need surgery?
No, definitely not. So there's a very specific population of people that need surgery. So let's start with how people present. So people present with usually an insidious onset of pain. It's not an acute traumatic event. It's intermittent pain. It's aggravated by sitting, walking, running, or really sport-specific activities that require excessive flexion or internal rotation of the hip. I don't know, how do patients usually present to you when they have FAI?
Yeah, so with FAI, it seems to be the 3 motions of the hip that irritate them are hip flexion, hip internal rotation, which if you see here, so here's flexion going back and forth, upwards and down. Rotation inwards is rotating this way. It's kind of hard to show on this model. And then adduction, which is bringing the thigh bone towards the midline. So those 3 motions typically irritate the patient that I see in the clinic. And usually it'll be like, I feel a pinch in the front of the hip when I go into a squat, or I'm playing my sport and every time I kick a soccer ball, I feel a pinch on the inside of the hip. And usually it's non-traumatical from what I see. If there was a groin strain, there was a mechanism of injury to cause that groin strain, that would be one thing. But typically I've seen it in more of an insidious onset, and it typically presents with a pinch in the thigh, the inside of the hip joint itself, or sometimes in the butt too. Not as typical, but that's typically what I see, what patients complain to me of.
Right. So really is a lot of it's groin pain, but when you have inflammation in the hip and you have compensatory motions, a lot of your other muscles can try to compensate and they can develop pathology. So you might have glute pathology that presents as pain, hip flexors. So it can present as a variety of different things, but most commonly it's that groin pain that you talked about.
No, that's a really good point, because sometimes I'll do an assessment and I'll do some passive range of motion of the hip, and I'll be like, well, this is stiff, but I have to think to myself, is it really guarding secondary to some type of pathology that's going on, or is this really a bony end feel? I mean, it's on me to try to figure and distinguish that.
And that's a great point. So I think for patients and therapists, it's important to understand what pathologies in the hip are modifiable and which are non-modifiable. So for FAI, in particular, your compensatory pathology, which, your glute weakness and abnormal motility and flexibility, maybe endurance and neuromuscular control, those are things that therapists can modify. But you can't really change the bony anatomy. So let's say, Arash, you have a patient that comes in, you're like, hey, I flex him up, I internally rotate, I can't get that internal rotation back. But if you don't know he has a big cam deformity, you might try to push that. But if you have an x-ray and you say, hey, I know I'm not going to be able to get that internal rotation because he has a big cam, that's a bony block. So I think it's important. Imaging is definitely important to figure out what you have going on.
Such a good point. And, I've actually made that mistake early on and found an impairment. Just because I found an impairment doesn't mean that I can improve that impairment. It depends on why that limitation is there. And if it's truly a bony end field, and I try cranking a patient's hip until where they're hitting their bone, they're abutting their bone against the bone, and I'm passively pushing that, I'm likely creating more harm than good. So what from a therapist perspective, what we need to focus on is constantly reassessing. And if we see that we can make a change after an intervention, we're on the right track. And if we're not making changes after a few times of trialing this specific mobilization, we have to take a step back and find a different way to approach the problem, because the way we're approaching it is not working out.
Yeah, and cool. that can kind of lead to like who should get imaging. So definitely, if you're asymptomatic, you don't need any imaging. If you're not having pain, you're not having loss of motion, you don't need any imaging. If you're symptomatic, if you have an acute injury, you're playing basketball, you have a hip sprain, give it a couple of weeks. People should get imaging if they have persistent pain after a couple of weeks, or if they have a shutdown period and they're still experiencing pain. And it doesn't have to be an MRI. So you can tell by X-ray allows us to tell the bony pathology of the hip. So we can identify that cam lesion on the front of the femur or that pincer lesion on the end of the socket by X-ray, and that will tell us kind of a little bit of what's going on. Patients that have that groin pain, and young patients particularly, we might get an MRI to identify soft tissue lesion. So that's your labrum, which surrounds the socket, or maybe the cartilage injury on the femur.
Mm-hmm. Yeah, very cool. All right, so let's go into conservative. So let's say someone does get an image. They see some type of pathology. It correlates to clinical signs. So remember symptoms. Like let's talk about symptoms real quick. What would they complain to you about?
So they usually come in complaining of groin pain. Hey doctor, I have groin pain whenever I squat, whenever I try to do the sprint or lunge or some kind of athletic activity. I have this groin pain.
Exactly. Sometimes some catching, clicking, locking potentially, but symptoms. So they have pain. And then we talked about clinical signs and then imaging. So make sure those three things are there and they have FAI syndrome. And then from there, now conservative treatment is what I focus on as a physical therapist. So first thing I need to do is rule out the low back or SIJ, the sacroiliac joint. So basically making sure that pain is truly coming from the hip. And so once I've done that, usually with testing, like a fader test is very sensitive. What I mean by sensitive means that if it's positive, I can likely rule it out. So I'm pretty sure if they're not positive with that fader test, that they likely don't have FAI. But once I've diagnosed it as FAI syndrome, At that point, there is not a consensus in the literature currently with how to best conservatively treat FAI. We kind of talked about finding the impairments and treating the impairments. A lot of times I'll find a lack of hip local stability and strength in the area. A lot of times actually the hip adductors I've seen to be pretty weak. But in general, the more strength you have around the area, the more active stability you have around this joint, the less pressure you have to put on the joint itself and being passive structures. So the more active strength you have with these muscles, the better off you are and less stress you have to put on these muscle or these passive structures, being the cartilage, the joint itself.
Yeah.
So
I think that's a really good point. And a lot of people ask the question, who will benefit from therapy? Like what are the patients that benefit from physical therapy? And the answer is that a lot of patients may benefit, but you have to, like we talked about, identify what's the base pathology of it.
Exactly.
And that allows you to more treat the modifiable factors. So if you have FAI, you're not going to be able to treat that bony pathology, but you can get better neuromuscular control, better core stability, better abductor strength, hip flexor strength, and that might mitigate some of their pain.
Exactly. No, good point. And so I can also modify some activities depending on what they're currently doing. If it is things like squats, CrossFit athletes a lot of times have these impingements, so I'll have to modify their movements. And I have another Instagram live I did about a month and a half ago, actually, taking people through a progression of how to strengthen a loaded movement from less hip flexion, like a front squat, into progressing to like a lunge, and then to a back squat, and then to a low bar back squat, and then eventually to a deadlift. Because you want to be careful with how much you get into a hip flex position.
Yeah. When you have a patient with FAI, what are your goals? Like, what do you set down for as their goals of treatment?
Well, they tell me their goals. So I guess it depends on what they want to get back to doing. And then based on what their goals are, I'll make micro goals, short-term and long-term, to get them back to what they want to do. But in terms of mobility, so I always break it down like this. Alignment, meaning, I don't know, if someone has excessive anterior tilt, these are quick fixes that we can do with motor control. Then I'll go into mobility. But like you said, not always are we going to improve the hip flexion, hip internal rotation, or hip adduction range of motion, especially if it is a bony change. And then I'll go into stability. In stability, I'll break down motor control and strength. So basically making sure they have that control. Because if someone is an anterior pelvic tilt and they go into a squat, I'll show you. What happens is that you may get a little premature abutment of the femur on the acetabulum. So motor control is huge with being able to control how deep you can go into a squat position. And then I'll work into dynamic stability. So that's typically my approach in making sure they have they've exhausted their mobility, and then they're working on, like you're saying, neuromuscular control, and then eventually getting into strengthening and getting back to what they want to be doing.
Yeah. Another thing that I know, I'm sure you do this as well, is educate the patients on activity modifications. Those are huge. So supportive shock absorbing shoes when exercising or working out, low impact exercising. Hey, if you have a big cam defects, you can run, but you might not want to run every day. So other things, biking, swimming, elliptical, walking, and really balanced exercises and improving proprioception are other things. There's assisted devices, weight loss. So there's not just one way to treat it. There's multiple things that you can do to kind of help that patient out.
Very true. So let's say a patient went to physical therapy and didn't get better, and now they come back to you. So let's take that next step. What's going on in your mind?
Right. So a patient has been having hip pain. It hasn't resolved with a shutdown. It's been persistent over a couple of weeks. They've had therapy and their therapy is not improving. So that tells me something is going on. So if we don't have imaging, I'm going to get imaging. Yep. I'll start with an X-ray. If the X-ray if the patient's young and the X-ray defines a big cam or a pincer deformity, then I might further evaluate that with an MRI. And an MRI is going to identify things like we talked about, labral tear, cartilage defects, and other structures that might be injured. Mm-hmm. And then from there, we can kind of talk about different treatments. I would give them the same treatments they've already had, options, non-operative management, therapy, but I would also talk about a diagnostic slash therapeutic injection. And
Yeah.
so, and those are kind of, is kind of a big diagnostic modality that we use. So the injection does two things for us. It contains usually lidocaine and steroid. So the lidocaine gives us a diagnostic, hey, if I inject this in your hip and you get better, I know the pain is coming from your hip. It's not coming from the muscles around. It's not coming from something extra-articular, your spine, whatever. It's coming from your hip. And then the corticosteroid gives you a therapeutic benefit, and that might give you some long-lasting pain relief. So that's another modality that we use.
How have you seen outcomes, just out of curiosity, with the cortisone injection?
Yeah, so the cortisone injection, usually there's two different patients. There's the young and athletic patient. So if you have a 21-year-old comes in, has FAI and a labral tear, you might give them an injection and they'll feel great. They say, hey, doc, that knocked out the pain. And so we know it's coming from their hip. But if she's a high-level gymnast or a football player and she goes back to those activities, she might have a return of that pain. And so you can't keep treating a 21-year-old with injections every 6 months or 46 months for the rest of their life. At that time, if they want to continue those activities, then it might be time to talk about surgery.
Yeah. Okay. Well, let's get into it. Let's see what in terms of surgery. Let's say they came to you, you tried injections. Maybe they're like this. Or sorry, were you going to give another example with the injections? You said one of two examples.
Okay. Oh yeah, another example. So a guy that me and you both know was talking to me about his hip pain. So he says he's chasing around his daughters. He has his hip pain in front. I'm like, hey, we play basketball all the time. You probably have a cam or a pincer, maybe even labral tear, but you've been living with this for 30-something years of your life. It's unlikely that it needs to be surgically repaired. So for him, I would try a more of a therapeutic injection, and he might get 6 to 8 months of benefit from that. Mm-hmm. And it might just knock out his pain forever. Yeah. So in those kind of patients, the injection is more therapeutic. Hey, let's see how long it lasts. If it lasts 6, 7 months, then that's something we work with. If it only lasts for a month, then it might be something we want to consider surgery with.
Interesting. Yeah, that makes sense. You brought up a good point. And the more I look into the literature, I see that typically these morphologies happen in people's adolescent years when they go into like a flexion and rotation sport. And what happens is you may be fine for the following years, but not until later on do you become symptomatic. And it's not necessarily that there was any bony change. There could have been, but likely it's developed at a younger age.
Right, and it could be those other mechanisms. So in that patient as well, therapy is huge because those patients particularly, and the pre-arthritic patients that have been living with it, and they might have some event that kind of knocks their neuromuscular control off or their pelvic, the core, those patients can benefit from modifying all those other factors to get them back to that low-level state they were at before.
Yeah, true. Okay, well, let's go into surgery then. In terms of it seems like there's a couple different options, but procedures that you would perform for either of these cases, or I guess it would be more so the first case, the 21-year-old. What would you be looking at in this situation?
So modern hip arthroscopy is minimally invasive. It's done through 3 small incisions the size of your fingertip. What we do is we stick a camera in the scope and we perform a detailed examination of the hip. So we identify anything wrong, any pathology that's going on in your hip. Any labral tears you have, we sew it back together with suture, and then prominent bone, either on the femur and your thigh bone, which is the cam lesion, or the pincer lesion sticking out in the acetabulum, we shave that bone down. And we do this through a hole in your capsule, and we sew that hole back together at the end of the case.
Very cool. Is there any other procedures that you commonly perform, or is that pretty much the most popular, most common?
Yeah, so those are the most common ones. For people with labral deficiency, there is labral reconstruction, which has gotten kind of big recently, but those are the main procedures that we do. So it's femoral osteochondroplasty, acetabuloplasty, and labral repairs are the bread and butter.
Awesome. And then can you briefly touch on the protocols that you put your patients through post-operatively for those procedures?
Yeah.
What you're trying to avoid putting stress on, compressive versus shear forces? Yeah.
Right, that's big. So usually patients are on crutches for 4 to 6 weeks. You can put about 20 pounds down on that crutch. So we call that 20-pound foot flat weight bearing. And then there's particular range of motion restrictions. So when we do the surgery in the front of the hip, we make an incision about right here through the capsule. So when we sew that together, we want to limit anything that's going to stress that capsule. So we don't want any external rotation of the hip. We don't want any extension of the hip. We don't want abduction past 30. So usually patients, will tell them, we don't want you externally rotating past 0 because that will stretch out that capsule we just repaired. We don't want you extending past 0. We don't want you abducting past 30. Those are usually for about 3 weeks. And at the 3-week mark, you start transitioning to weight bearing and start trying to wean off those crutches. And then in terms of physical therapy, we pretty much start physical therapy day 1. And therapy is at day 1 is just for mobility. We want to keep that hip mobile with passive range of motion. And really we kind of divide it into 3 to 4 different phases of therapy. Okay. Phase 1, your goal is to protect the joint and limit irritation. That's when you're really non-weight bearing. We don't want anything to kind of inflame and cause you more pain. That phase 2 is when you start weight bearing. It's non-compensatory gait and progression. So that's when you start walking, slowly weaning the crutches, and you want to really avoid any of those compensatory patterns. And then after you graduate from that, you go into phase 3, which is you want to return the patient to the pre-injury level. So you start, running and doing things like that. And then for our very active patients, there's a phase 4, return to sport, and then you start doing sport-specific activities. Yep. And so you want to have kind of criteria to pass through each phase rather than a discrete time period.
Yeah, and this goes to one question that we got through a direct message. On average, how long would it take for someone to return to sport after a procedure like this?
That's a really great question. So we like to say it's sort of similar to ACL. So you have a 3-month intensive physical therapy sessions, and then you kind of progress based on your progression at that time. So usually it's 4 to 6 months.
Mm-hmm. Yeah. I actually saw a study. I wrote it down here. I saw a study by Casartelli et al. It was talking about return to sport. And I saw after surgery for FAI, 81% of professional athletes returned within that same year, which is pretty interesting. And then 62% the 3 years following that surgery. So short-term outcomes seem pretty good. And then let's see. I haven't even checked these comment threads. Are you guys still with us? It seems like 62 of you guys are still here. Thumbs up if you guys like this so far. Ask your specific questions, and we'll go through them. Right now, I'm going to ask some of the questions that we got previously, and then as I scroll through, I'll kind of like mix the two. But let's say I have hip pain. I have hip flexor pain after deadlifts. Exercises to fix this. Okay, so I'll address this one real quick. But likely the pain at the front of your hip, just because your hip flexor is also at the front of your hip, doesn't mean that it's your hip flexor. Like we discussed, what can happen is you can get an impingement as you go into hip flexion here, where you get premature contact with the head of the femur to the acetabular rim. So that's what can be creating what you're perceiving as hip flexor tightness. And at that point, you want to progressively go through the exercise that we kind of talked about, slowly improving mobility, developing control of your pelvis, hip muscles, and then strengthening.
Yeah, and I can kind of touch on that too. I mean, if you're having hip flexor pain and doing deadlifts, you might want to stop doing deadlifts.
Yeah,
that's the easiest thing. You kind of think about it as hip flexor pain specifically. If that's what it is, it's more commonly due to overuse. So you might want to shut it down, stop the activity that's causing the pain, and allow your body to heal. And then you can kind of build up and get back to doing your deadlifts.
Yeah. And then next question.
Manual therapy. There's local medications you can do, but you really want to gain that normal range of motion into hip extension. And then you could also do some joint mobilizations to kind of build that up.
Yep.
For hip flexor specifically.
Yep. Let's see. Next question. What is FAI due to insufficient posterior pelvic tilt? I briefly talked about this, but if you have excessive anterior pelvic tilt, you're also creating less room here. So what can happen is that if you're starting in this position, you're more likely to impinge than if you were to stay in a neutral position. So that can potentially contribute to it. And that goes back to what we were talking about with neuromuscular control or motor control, and making sure that you have a good control of your pelvis as you go through movements. If not, and you fall into excessive anterior tilt as you go into a squat or as you go into any hip hinge, then it can potentially put you at risk for irritating your hip.
That's a good point.
Let's see. Acetabular tear in my left hip. Can it cause groin testicle pain? I mean, we kind of talked about that.
We kind of touched about this. The most common presentation for FAI is groin pain. And that can present a couple of different ways. That could be referred to different areas, but usually not testicle pain. That could be something else.
Mm-hmm. Yeah. What is your experience success with non-operative management? I've seen a handful of patients. It depends what you define as success, because some people do have to live with some activity modifications for the rest of their lives, or make sure they stay consistent with prehab exercises. But for the most part, I've gotten people back to a higher level of function than they came to see me at. I don't know what you've seen from your experience as well, but
yeah, I think the right patient population definitely has great results with physical therapy. So that older population, the population that's not doing, Olympic activity or, professional sports, you can definitely get some benefits of physical therapy and those compensatory patterns that develop in muscle weakness, core stability. Those will all decrease your pain, and you might be able to live with that low level 1 or 2 pain.
Yeah. Here's a question. I'm looking at the comments. Dr. Dark and Lovely, what can CAM lesion lead to? I did see something about potential osteoarthritis down the line with CAM lesion specifically, but I don't know if you wanted to talk a little bit more about that.
Yeah. So basically, I kind of bring the model back out. When you have a CAM deformity, you have that bone, excessive bone on the front of your hip right here. And so when that impinges, you can get damage to your labrum and your cartilage. And that cartilage, when that cartilage degenerates, you don't have that smooth kind of function of your hip anymore. And that can lead to osteoarthritis down the road.
Yeah. Another analogy I like to use too, like let's say this is the ball and socket of the hip. And if you did tear some of your labrum, what happens inherently is the joint is less congruent. And so now you really need to stabilize the hip because there's less passive stability that your hip joint that previously was stable has to offer. So you really need to strengthen those people. If not, you can rely a lot on those passive structures.
For sure.
Let's see. Nancy on the move. Does hip impingement ever impact or could lead to tissue pain or inflammation around the hip joint? Or would that tissue pain likely be caused by something else?
No. The tissue pain can definitely be caused by the bony contact, the bone abnormality in the bones when they impinge causes injury to the labrum. And the labrum can also release different factors that cause inflammation in the hip and swelling in the hip. So all that can be caused by the bony anatomy.
Yep. Here's another one. What would you guess? This is by Nancy on the, wait, she just asked. Just asked the same question, or a different question, but same person. Nancy on the move. What would you guess would be the cause of pain in the tissue muscle around the hip joint, IT band, particularly a burning? So any specific questions we really need to assess before we give you exact diagnoses. So it's hard for us to say based on the information. We always recommend seeing a healthcare provider in person, just to be as specific as possible. We wouldn't want to steer you down the wrong way. That would be a disservice on our end.
You really have to have the whole picture to give medical advice.
Here's Azil Dev. Can a twisted cartilage be seen on x-ray? I don't know what a twisted cartilage is.
Not a twisted cartilage. You might be able to see deformity in the femoral head or acetabulum. So you can definitely see cartilage. You might be able to see bony defects, but the cartilage is best seen on the MRI.
Here's Maxime Fit. How can stem cell be used to mitigate FAI? I'm not sure if I haven't seen anything specific on this.
Yeah. So there's that, along with the injections, there's different injections that you can inject in the hip. There's steroid you talked about, there's PRP, there's bone marrow aspirate concentration. And the bone marrow and the PRP, the stem cells, those are all new adjuvants that haven't shown really unified positive or negative responses, but some patients actually benefit from them. So that's definitely something you should try. They're a little bit more on the expensive side, but they've shown some promising results in some studies.
JB Smooth 601. Will I get CE credit for this lecture? Thanks in advance.
JB Smooth.
Let's see. Let's see what else people have previously. Here's another. How are failed hip scopes treated? Labrum is detached, frayed, and torn. Capsule defects, too much bone resected.
Right. So that's that gets into revision hip arthroscopy. So if your labrum is detached, frayed, or torn, that's when we consider either labrum augmentation or labrum reconstruction. And those two things are they're really different things. So labrum augmentation is when you have a labral tear and we try to keep as much of your normal tissue as we can, and then we add tissue with either a cadaver tissue or some of your own tissue locally to try to build you a new labrum. A labral reconstruction is when we find that your labrum is so deficient that there's basically nothing left. And so then we build you a new labrum, again, either out of allograft tissue, which is cadaver tissue, or locally we can take some of your own tissue and try to rebuild your labrum to kind of mimic that function that your natural labrum provides. Mm-hmm. Now, as far as what were the other defects she was asking about?
Capsule, labrum detached, frayed, torn, capsule defects. I'm assuming that's part of.
Yeah, so capsular defects can happen a couple different ways. So if a surgeon fails to close your capsule, which when we originally started doing the surgery, not a lot of people closed the capsule, but now that we're finding that capsule closure is important to keep a stable hip. So
you're breaking up there, Case. Can you repeat that last part real quick?
Yeah, I said back when we first started performing the surgery, a lot of people didn't close the capsule, and there wasn't a lot of literature about it. What we found is people have continued pain or instability due to that capsule being open because your hip can really slide out of the joint. So most surgeons start closing the capsule. Now, if you have a defect in that capsule and you're not able to close it, we can then augment it with, again, some cadaver tissue to kind of do a capsular reconstruction. And then the third problem is a bony defect. So like I said, during the surgery, we shave down some of that bone. And some patients, they get too much bone resected. And that can cause instability, and that's a totally different animal. So for that, usually we use a bulk autograft. So we get a dead person's maybe femur, and we try to cut off a piece of that and then attach it to your bone and secure that with screws. That's done through an open surgery, though.
But most of the ones you were talking about were arthroscopic, correct?
Right.
Okay. And this leads to the next question, actually. Do you end up finding a total hip arthroplasty is common after getting an arthroscopy?
A total hip
A total hip replacement. Yeah.
It's common after getting a hip scope. So
Yeah.
I don't think it's common after getting a hip scope because that's what we're trying to prevent. We're trying to prevent
Right.
the patient. We're trying to let them go back to their activities. We're trying to prevent arthritis. I think it's too early to say whether we are actually preventing it or not, but that's our goals is what we're trying to do. And I don't see often that people will have a hip scope and then get hip arthroplasty
That's
within the next
exactly.
year because they're
The
usually
goal
not
is to
those
avoid.
patients. We're not doing hip scopes in 70, 60-year-old patients with arthritis. All right.
Yeah, I saw that too. Interesting you just bring that up. But with hip OA, it seems to be that scoping for FAI syndrome is not really an indication, correct?
No, scoping for FAI is an indication because we can shave down that bone. But if the patient has advanced arthritis, that's not an indication.
It's
that's
not an indication. Right. If they have OA. Okay. This is a recent question. Exercises that you clinically have noticed to help with FAI. Again, we kind of talked about this. I have a whole nother Instagram live taking people how I progress them from phase 1 all the way to progressively loading them. So I would check that out.
Is that for post-op?
No, it's not post-op. It was just pre-op, dealing with just conservative. I didn't go through post-op, but
that's good. I'll check that out.
Yeah, so it's basically taking people from motor control to improving mobility, like we're saying, especially hip flexion, adduction, internal rotation, with reassessing, because like we said, if you're abutting the bone against the bone, you don't want to just keep cranking into that. But more importantly, developing motor control with the muscles that are surrounding the hip, in addition to the pelvis, and then loading up with strength of the area, more active stability, the less stress you put on the passive structures. Let's see. There's a bunch of questions.
Nancy on the move. Questions.
Did she ask another question?
Is it possible to develop FAI in a short period of time due to overtraining, less than a year? So like I said, FAI is usually an insidious process. So usually develops over time. And if you're overtraining in a week or 2 weeks, that wouldn't be FAI. You might have a labral tear or other problems going on, but usually not FAI in a really short time period.
But does it fix dysplasia? By S. Marcus 07. We really didn't talk about that. We didn't. But did you want to touch on dysplasia?
Yeah, I can touch on dysplasia, but could be a whole different hour talk.
Yeah,
I could just say dysplasia. When we're talking about the surgery that I talked about, it's really not for the dysplastic patient. The dysplastic patient might have a different rotation in their femur or acetabulum that needs to be corrected with an open surgery, but that's a kind of a different topic.
Yeah, well, maybe save that for another live.
Yeah.
Cool. There's a few other ones, but last minute questions if anyone wants. We'll stay on for another 5-10 minutes. How are you doing on time?
I'm
do
good.
that for 5 minutes, because I know that there's a time limit for Instagram.
It's just 1 a.m. over here. I'm doing good.
That's right. You're out there in Chicago.
NCOPE 03. What is the criteria for a successful labral reconstruction surgery? So I think everybody's criteria are different, but what we really want you to do is get back to your activities of daily living or whatever activities you were doing before the injury. That's what we want to try to get you back to. So if you're saying you want to get back to exercising at home, jogging, running, that's what kind of activities we want you to get back to after the surgery. And really pain-free motion is a really big goal.
That's the goal, yeah. Fat nature, veg kid, spinal mobility, affect hip. Everything is connected. So typically I actually see that vice versa. I see the hip limitation affect the spine. So what happens is because they have limited hip mobility, they rely on other means, which is like lumbar spine or the low back to excessively move. But it can also work the other way. Would love to hear about dysplasia. from Madeline Steezy. We'll definitely have to do one soon about that.
Yeah,
Cool.
for sure.
All right, guys, we're going to call it for tonight. That was cool. That was a good time. Hopefully you guys learned some stuff. Thanks, Dr. Okoroha, for joining us today.
Thanks for having me.
Yeah, any other questions that you guys have, you can DM us. We'll